This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 23, Intubating Airway Management. Key concepts. Upon completion of this chapter, you will be able to understand the implementing of intubating airway management, entitled Carbon Dioxide Monitoring, the gold standard of proper placement, principles of patient airway assessment and how to make the first attempt at endotracheal intubation the best attempt, a backup plan using rescue devices when faced with a difficult airway, post-intubation care, and special considerations in airway management. So this is figure 23.1 in your book, and this is intubating airway management algorithm, and it essentially starts here. Kind of works its way down into the side. Patient assessment. So at this point, you have initiated a patient assessment and determined that an intubation is required. Pre-oxygenation and ventilate as needed and prepare your equipment. If the patient's breathing, consider a nasal intubation. Attempt oral tracheal intubation. Was it successful? If yes, then confirm with 3 methods: secure the tube and monitor the patient. If it wasn't, ventilate, reassess, reassess provider, patient, and equipment, and we'll talk about that here in a second. After attempt 2 successful, no. Ventilate, prepare blind insertion airway device, and this would be like an LMA or a King airway. We'll talk about those as well. Attempt the blind insertion airway device placement. Was it successful? Yes or no? And then very simply, most of these over here are, if it was yes, then confirm the position on the airway, secure it, and monitor the patient. If the blind airway did not work, go back to BLS methods as a kind of a retreat. Attempt to ventilate with BVM or automated transport ventilator. Was that successful? If yes, monitor the patient and transport emergently. If no, consider obstructed airway. If unable to clear, attempt surgical airway. And was the surgical airway successful? Yes, monitor the patient and transport emergently. Or no, transport patient emergently, consider requesting physician intercept. Equipment for intubating airway management. Now, very simply, look at the skills section on this. So whenever we talk about things like endotracheal tubes, laryngeoscope, most of these are psychomotor skills that you'll be working out in the lab. So you'll need an endotracheal tube, very simply about the size of the patient's little finger, a laryngoscope, a stylet, securing devices of some sort, and secondary confirmation equipment. Now, the confirmation equipment, we'll look at them here in a second. They can be things like capnography, colorimetric end-tidal CO2 detectors, or an esophageal detection device. We'll take a look at some of those. Some kind of rescue device as a backup. So rescue devices are things like our blind insertion airways. So things like the combi tube, the LMA, the King airway, all are considered rescue devices. So we have a place to go back to. So if the intubation was unsuccessful, we have the ability to facilitate an airway. A gum elastic bougie that can also add more tools to our bag of tricks, if you will. Lighted stylets, laryngeal illumination intubation. This kind of gives us a illuminated stylet so that we can see the light through the cricothyroid membrane. And then, last but not least, a surgical backup airway. So, endotracheal tube intubation equipment should be kept in one location to where it's all easy to get to. So, oropharyngeal airways, extra blades, ready to go, McGill's, 10cc syringes, and generally these will have secondary packs on here, or you can just lie them in here like this, of your ET tube. ET tube with stylet. This would be an esophageal detector device. So all of your stuff essentially in one location. Now this is an endotracheal tube. This is the top of it, and this is a universal connector that will connect to the BVM. Now, very simply, be sure that these are connected whenever you start to ventilate, or sometimes you can pull this off of there and just have the tube. So then where did this go? Is it still in the end of my bag? This is a distal cuff, and the air pressure that you feel here when squeezing it is generally the air pressure that is in here. There's a Murphy's eye down here, and it's a good spot to be able to locate. The stylet that goes in here and makes this rigid should not go below the Murphy's eye. A Macintosh blade, and the proper technique for this is a curved blade. This area right here goes into the vallecular space, which is just above the epiglottis, and you should pull the laryngoscope kind of in this direction. If you bring it back, you can fulcrum off of the teeth and chip these off into the back of the airway. Now you have foreign body airway obstruction problems. So proper placement for this is in the vallecular space. Very simply, either get your thyromental angle correct and know the depth that you should be inserting the laryngoscope, or take little small slices out until you see structures that are easily identifiable. Same way with this. This is a straight blade or a Miller blade, and the Miller blade kind of goes in there, grabs a hold of the epiglottis. This is the different, and still kind of moving in this direction, and the Miller blade should be pulled back until we can visualize the glottic opening. Again, any kind of fulcrum created on the teeth will break off the teeth in the back of the throat. Stylet in place, and on this one here we can actually see the Murphy's eye, which is right here. The stylet itself should not go anywhere below the Murphy's eye. It could cause trauma to the airway. These are various types of connection tubing, and this over here is a Thomas tube holder, which it really secures the airway well. The tube goes in here. This is screwed down to kind of jam it in place, not enough to where it makes it go flat, and then this is wrapped around the patient's head and velcroed. This really secures the tube well. This area here is an area that allows for suctioning of the patient. Now, these are conformation devices. This is an esophageal detector device, and what it does is there is residual volume in the lungs. So if this thing is mashed flat and placed on the end of the ET tube, very simply, if it's mashed flat and then you attach it, there will be residual volume. So this thing will pop up almost immediately. And the same way with this. If this is placed on the ET tube and you pull the plunger back, it will flow quite nicely. Now, the esophagus is not semi-rigid, so if you apply pressure on it, what will happen is the esophagus will go from this to where it will collapse, and that won't allow for the airflow to occur nicely. This here is a colorimetric end-tidal CO2 detector, and if it comes into the presence of CO2, it changes colors, and the color to remember is as good as gold. So it's going to turn a golden color, about the same color as the slide set here. These are rescue devices or backup airways, and the rescue devices here, this is the King. These are all blind insertion devices that I'm putting a check mark on. The King LT, we essentially insert it blindly and then get it into position to where we think is correct here, and inflate these two tubes. And what happens is this area here has holes in it. So what it allows for is it allows for air to flow out of here. Now hopefully we have that in the position to where it is covering or in the area of the glottic opening. And this will blow up in the oropharynx, and this will blow up in the esophageal area, and this will ventilate our patient. Laryngeal mask airway is similar, blind insertion device, only the mask, if this is the esophagus, and the green is the trachea. Epiglottis. The LMA airway, essentially, let me back up one. The LMA airway essentially masks the glottic opening so that we have equal rise and fall. Now, this works pretty good if you can verify that your patient has not had any kind of food within the last 12 hours. They use these as surgery quite a bit. The problem with it is there could be pressurized Taco Bell in the gut, which could easily ramp up and cause aspiration with an LMA device. Last but not least here is the combi tube, and this has 2 balloons as well and holes in this area here. Now, what the holes do is this blows up in the esophagus, this blows up in the oropharynx, and all these holes allow for ventilation of the glottic opening. And this is a simple process: inflate tube 1, inflate tube 2, ventilate tube 1, ventilate tube 2. And just whichever one causes rise and fall of the chest, we confirm that really quick. It's always a good idea to confirm it with some kind of CO2 confirmation, like capnography or colorimetric, to be sure that we're in the right location or we're ventilating appropriately. Sometimes ventilating the stomach can move the chest as well. And this is a gum elastic bougie. Now, what the bougie does for us is all of the airway has these cartilaginous rings on it. And this little curved tip here gives us the ability to insert it down if we can only see a part of the aretrenoid, which the aretrenoid cartilage lies below. Anything anterior to the aretrenoid cartilage means that we have the tube in the right location. So if we can't visibly see the airway, and we can only see about this much of it, and this part down, what we can do is we can use a gum elastic bougie. It's already kind of curved, and place it into where we think it is, and kind of run it up and down a couple of times. Running it up and down gives us the ability, since this is kind of curved here at the end, to fill those cartilaginous rings that we had talked about before. It'll feel like little clicks as it goes across them. Now, what that does is the esophagus does not have cartilaginous rings in it, so that kind of gives us a confirmation of we have it in the right location. A lighted stylet gives us the ability to run down a stylet, and in between the thyroid and the first cricoid ring, there's a cricothyroid membrane. So if we have it in the right location, we will actually see light being emitted from the middle of the throat. Transtracheal jet sufflation. This is from a needle cricothyrotomy, and after the needle cricothyrotomy is placed, this device blows large amounts of air through this needle. Now, what it will allow is it'll allow us to ventilate somebody. We're still have a problem, though, with air trapping. So the oxygen goes in, but the ventilation comes out really slowly because normal ET tube size, about like that, well, the lumen on a 14-gauge angiocath is very small. So they will retain CO2. Just be aware of that. It'll take about 4 to 5 times longer than it took for inhalation using a jet sufflation device. Patient preparation. This occurs in 3 ways. This occurs with assessment, positioning, and if needed, medication administration. So things to consider. Are they male gender? Obesity? Age between 40 and 59? Decreased mouth opening is always a thing that we should consider. How much will their mouth actually open? Poor visualization of the hypopharynx. Limited neck extension. Receding chin. This is all going to get in our way whenever we're trying to look at the glottic opening. Abdominal distension. Large tongue. Beards. supraglottic mass, if they have a mass in their actual throat. A trauma patient where we have to keep their head more in line. A pregnant patient, a Mallampati score less than 2. And we're fixing to look at the Mallampati here really quick. Mallampati score assesses how much of the uvula and the back of the oropharynx that we can actually see. So this is a class 1. There's plenty of room through here. Let me change colors on that. Plenty of room through here. So if we moved it in this direction, hopefully we'd be able to see the glottic opening. This is a class 2 Mallampati. Soft palate, uvula, fosses are visible, but again, decreased angle. This is a Mallampati 3. I can't see the back of their throat. All I see is tongue and uvula. And this is the hardest airway, which is a Mallampati 4. Hard palate only visible. And this is really severely difficulty. Now, most of these airways will fall under the classification of a 1 or 2. But as we are becoming more obese as a nation, we will probably see more and more difficult airways. Sniffing position is always the best. So positioning, this is what it means by positioning the patient. Placing them into a neutral inline position so that we get the best chance of seeing the glottic opening. And then head, tail, chin lift if there's no trauma. Pulls it back and positions it so that the jaw has to move less, and we can see our glottic opening easier. Oral endotracheal intubation. The steps on this, and this is skill 23.1. You have a psychomotor skill sheet and a video with this. Visualize the vocal cords passing the endotracheal tube through the vocal cords. Visually confirm that, confirming endotracheal tube placement. And this is by about 3 methods. So we saw the tube go through the cords, equal rise and fall bilaterally, and then now generally we use end-tidal CO2 detection and securing the endotracheal tube. Nasotracheal intubation. This is skill 23.2. Patient preparation, need to have them kind of set up right, put them into a sniffing position, intubation, and then confirm placement. And this is going to be a blind stick running down the nair very gently so you don't cause bleeding of the nair, and then securing the endotracheal tube. A failed intubation. Rapid assessment must be performed if we fail an intubation. This should focus on the operator themselves failing, patient preparation failure, we didn't get prepared enough, or equipment failure or incorrect selection. Other options that we can look at here are endotracheal intubation techniques, and this is skill 23.3. The gum elastic bougie, which is what we had talked about a few slides ago, which gives us tactile sensation of the cartilaginous rings. Translaryngeal illumination, or lighted stylet, and then fiber optic stylets or bronchoscope. Now, some services actually carry nowadays a poor man's kaleidoscope or a actual kaleidoscope in the back of their ambulance to assist them in intubation. This is a digital intubation. The only thing that I would suggest here is please be careful if the patient has had a seizure, because there's teeth right there. Our fingers do not grow back quickly. They don't grow back at all. So if the patient has a seizure or clamps down, you could cause injury to your own digits. So just be aware of that before choosing digital intubation. Supraglottic airway devices are things like the King LTS-D airway, and this is skill 23.5, the laryngeal mask airway, and the esophageal tracheal combi tube. As far as LMA placement goes, we essentially get it down into the back of the throat. Tongue depressors work good. Fingers also work good, but again, be careful. This here is the combi tube and its placement, and this is how there's a bunch of holes in here. Once these balloons are blowed up appropriately and the tube is ventilated, air will go into the trachea and cause rise and fall of the chest. A BVM and automatic transport ventilator, mask to face ventilation. Now, be careful with these that you are getting good rise and fall of the chest. If you're under BLS means, it leaves a free open access to the esophagus. So whatever you fill up in the lung, if you have the tidal volume set up too much, very simply it'll blow over into the stomach and you'll pressurize it. A surgical airway. The surgical airway we'll refer to here is the surgical version of it, which is skill 23.6, and the needle cricothyrotomy, and then percutaneous devices. There are some rescue airways that already have a sharp, very large needle into them, and will dilate out the cricothyroid membrane area. And these are very helpful if you don't have the ability to perform a surgical airway. Post-Intubation Care. Again, refer to the skills on these. Post-intubation care, as far as the goal of an emergency airway management is to actually oxygenate the patient. Proper post-intubation ventilation is critical to minimize hypoxia. Orogastric or nasogastric tubes could be placed as well, especially if the patient has been under BLS methods of airway control. The stomach is the path of least resistance, so after we fill up the lungs with air, it'll roll right into the stomach. So overventilation sometimes causes a pressurization of whatever the patient had been eating in the stomach and will cause them to vomit and aspirate. Tracheobronchial suctioning is also important. After we facilitate an intubation, we might actually have to send down an endotracheal suction catheter to remove particles, food particles, mucus, and whatnot. Special circumstances, stoma management. There's two types that we need to talk about here. One is a tracheostomy, which essentially just means hole in the trachea. Now, a tracheostomy is the perforating circular stoma hole that most of us see whenever we're looking at people with a surgical airway or a long-term airway. The people that have a laryngectomy, and you need to be aware about this, just because they have a stoma doesn't mean that they have an oropharynx that's attached to it. The individuals that have had a laryngectomy or removal of the larynx sometimes will have, or most of the time will have, just a pocket of skin that is put over the tracheal opening because they've had their entire voice box removed. Now, in doing so, if you try to orally intubate these individuals, you'll never hit your mark. The management must be done through the stoma site or the front of their neck. And trauma patients, important considerations. Airway injuries, cervical spine movement are always a concern. Chest wall and pulmonary injuries that could decrease alveolar space. And then if we need to provide an airway, then we should really consider sedation and paralysis or the utilization of medications to facilitate an intubation. The pediatric patient, best practices, very simply, this is mixed results as far as statistical proof. Studies have shown that paramedics can perform pediatric endotracheal intubation, although they usually have higher complication rates and lower success rates than with adults. So statistically, we're not doing so hot on this, so practice makes perfect whenever we get to the pediatric patients. Advanced airway management algorithm, patient preparation, pediatric intubation, tube placement confirmation, and airway rescue devices, and then a surgical airway option. And in most children, the surgical airway option is kind of out. Challenging, it's difficult. The needle is the only version of any type of surgical airway that we would provide on a kid. So as far as patient preparation, we had talked about in the anatomy of kids earlier that their occiput generally gives us complications whenever we're trying to look at the glottic opening. Pat out their shoulders to where we can get them into a neutral inline position. As far as the pediatric intubation goes, the adult airway is the size of a dime. A pediatric airway is 1/3 that size. You're hitting a smaller target. Technique is essential. Tube placement confirmation. Once we have the tube in the right location and the appropriate size tube, and it would be my suggestion to you to use a colorimetric device on the actual tube size or Brazos tape, weight-based tape, essentially, so that we give the appropriate size ET tube. Now, since they are uncuffed, Please pull out, whenever you're intubating, a tube size below and a tube size above. The tube itself should provide a friction fit into the cricoid ring. If it does not, then the airway is not the appropriate size. Airway rescue devices, so we need to have a backup plan, whether it be a BLS backup plan, or they do make pediatric King Airways. Surgical airway options, like I said, there is no true surgical airway in a child. The needle cricothyrotomy would be our best options. Also remember when applying that you are on the time clock now. They will retain CO2. Conclusion. It is critically important that the paramedic master basic and non-intubating airway management. However, the definitive management of an airway involves endotracheal intubation. Even under the best circumstances, there are times when a paramedic cannot intubate a patient. Therefore, it is important for the paramedic to have a plan and alternatives. Advanced airway management algorithm used along with the paramedic skills should provide the paramedic with the tools necessary to perform definitive advanced airway management. References for this lecture are from Richard Beebe, Professional Paramedic, Volume 1, Foundations of Paramedic Care, First Edition, pages 424 through 473 of Del Mar Learning. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 45219-7613. Thank you.